Distinguishing a small atrial septal defect from a patent foramen ovale on an echocardiogram hinges on identifying whether there is a true anatomical deficiency of septal tissue or simply a failure of normal embryonic fusion. While transthoracic echocardiography can often identify these features, transesophageal echocardiography remains the gold standard for definitive anatomical assessment of the interatrial septum. 2D anatomical features. The most fundamental difference is structural. Small atrial septal defect, that is secondum variety, you will see a fixed continuous dropout of tissue in the region of fossa ovalis. The defect is persistent throughout the entire cardiac cycle, and the edges of the atrial septum, septum primum and secundum, clearly do not meet. PFO, there is no missing tissue. Instead, you will see a flap-like separation where the septum primum and septum secundum overlap but fail to fuse. The tunnel or slit-like opening is often transient, opening briefly during specific phases of the cardiac cycle, usually early systole, or when right atrial pressure exceeds left atrial pressure. Color flow Doppler. Color Doppler helps visualize the geometry and timing of the shunt. Small ASD. Color flow typically demonstrates a continuous central and relatively broad band of left to right shunting across the defect. The flow is usually present throughout the cardiac cycle. PFO. Flow is typically intermittent and pinpoint or slit-like. Because the PFO acts as a flap valve, you will usually see a narrow channel-like jet. In the absence of elevated right-sided pressures, you might only see tiny, fleeting left-right flow. Agitated saline contrast, bubble study. A bubble study, especially combined with provocative maneuvers, is critical for differentiating the two when 2D and color Doppler are equivocal. Small ASD. Micro bubbles can be seen crossing the septum from right to left at rest, though a left to right shunt might initially keep bubbles out of the left atrium. A negative contrast jet can sometimes be seen washing bubbles away from the right side of the septum. PFO. At rest, there is typically no right-left shunting. Right-left shunting of micro bubbles into the left atrium usually only occurs or significantly increases during the release phase of a Valsalva maneuver or after a cough, when right atrial pressure transiently spikes higher than left atrial pressure, pushing the septum primum flap open. While transthoracic subcostal views align parallel to the interatrial septum and provide excellent Doppler angles for detecting flow, transesophageal echo provides the spatial resolution necessary to measure the exact overlap of the septum primum and secundum, the tunnel length, in a PFO, which is critical for planning transcatheter closure if clinically indicated.